Ted, take you first. So much of the past attention on healthcare safety has been in the hospital setting, and obviously as a plastic surgeon, you understand that perspective very well, but now you're a physician leader in a medical office group. What's it going to take to get those smaller provider organizations to embrace this notion of continuous improvement systems that's at the core of the roadmap?
Yeah, so when I looked at the 5 goals, to me the first goal was the most important goal, the leadership and culture goal, because I think that's the bubble that should be around all the other 4, because to me that's the most important aspect of how you will inculcate this into organizations. And I think when you look at what you're building on the leadership and culture side, it has to integrate, and you heard from the first set of panelists, that how it has to integrate the entire vertical of healthcare, everyone that is involved in healthcare. In terms of embracing it, I think everyone that's involved in healthcare really understands the value that they bring to the patient experience at every level, and that has to be reinforced as well. So it's not only including leadership and culture, but looking at leadership and a culture of safety, a culture of empowerment, a culture of value, a culture of accountability that has to happen at every level. Everyone has to feel empowered to participate in that. And I honestly think embracing of it is fairly easy, because as clinicians, as everyone involved in the healthcare vertical, we're all there for one goal, and that's really to take care of patients and provide the best care and highest quality care and safest care for our patients. And I think that's the core of what we do. It was really good to hear that these goals will be sizable and scalable and adaptable, because I think it is different. Realizing that about 80% of the physicians in the Commonwealth are now employed by healthcare systems, and there are smaller numbers of physicians that are in primary care and small practices. I do think even those physicians that are employed by large systems, all politics is local. I have my little office, everyone has their little office, and what physicians and other healthcare leaders in the offices need to realize that as clinical leads, they are the de facto leaders in their practices. And by doing so, by understanding their relationship to the people that are working within their practice, they will set the tone. So that culture of leadership that we speak about, that vertical integration has to happen at a grassroots level at every practice for us to be very, very successful. I do think that the other thing that we need to look at is how will we respond to failure? Because even though we want to be successful, we will fail. And the leadership and culture around responding to failure, I think, is important, and how that's done at the local level, within the office, how that's done at a bigger systems level as well. Again, the not one-size-fits-all approach is going to be important, especially as we look at integrating this into private practices that may have workforce challenges, is how do they integrate this seamlessly into their DNA? And it's not viewed as additive, but it's really viewed as integrative. And it's part of what we do every day, taking care of patients.
Organizations learn from what CHCs have been doing to eliminate these kinds of disparities.
Yeah, thank you. First and foremost, just glad to be here and be part of the conversation. I was walking up to the podium and had a quick conversation with Dr. Hackner, and both of us have been intrigued by this notion of the weathering effect. The fact that we've gotten used to certain conditions, certain communities dealing with disparities, and I think that's an interesting place to start when I think about the role of community health centers and the work that we've done in that space. What stuck with me this morning as I heard the earlier panel was, why do I have to get angry to get the care that I deserve? That there's always something that happens in a forum that sticks with you. That quote by Deb Washington, quoting a patient, stuck with me. So from a community health center perspective, and I think about the panel earlier, patient engagement, community engagement, and the care that people receive, and ensuring their safety within the places they go to get care. Health center boards are over 50% consumers. So I remind people there's no other model like that. And many of us in this room serve on boards. Imagine if 50% or more of the people who sit around the table could say, I don't like how clean the waiting room is, or they didn't speak my language when I walked in the door, or I don't think my provider is culturally competent and doesn't believe that pain in my side is real, or I think there's some error in the prescribing that I receive. So one is we have consumer boards that have a seat at the table to engage in that way and drive the policy of our organizations. Another thing that health centers have done that have really been on the cutting edge of what we're now thinking about around how to provide care is patient-centered medical homes. That's the buzzword in the last 10 or so years. But the reality is you could walk into a health center and not only were your challenges with social determinants of health being met, but also we were treating your teeth, your eyes, your mental health, your substance use disorder, and even in a greater way. Another aspect that I think we're growing into is this notion of collection of data, which we didn't do very well in this country, and we didn't do very well during the pandemic. Health centers have really strong race and ethnicity data, SOGI data, that we collect, that we can use, that we try to implement into our models of care. And then sort of last but not least, I think, that which gets measured gets done. And in this sense, whether it's HRSA, the Bureau of Primary Health Care, whether it's the Federal Tort Claims Act, because health centers are covered under the Federal Tort Claims Act, there are requirements that come with that around patient safety and quality that we have to meet and that we're annually evaluated on. That creates this expectation that the patients who walk in your door is not just about the challenges that we all face, workforce, funds, resources, but that you're being evaluated on those things. And I think the accountability part that's mentioned in the roadmap is in existence in that health center model. Everything can be. I think about when I was at Blue Cross many years ago was when the report came out to Err is Human, and I remember how shocked I was, but not that shocked by the report. And there were two really reports that stuck in my head: unequal treatment and to Err is Human. And I really thought to myself, wow, I wonder how many of those errors are also race and ethnic based within the settings that we get our care. And there's a story to tell about disparate treatment or about the errors that happen in our systems. I'm excited that some of this work that has really been keeping up health center leaders across the state for many years is now a broader conversation around how we can address those challenges.
A major theme of the roadmap is this role of leadership in building a safety culture. And you're the CEO of a hospital. What does it mean at a practical level? In other words, how do you sort of trickle down those priorities to the front lines?
So first of all, my background and training as a nurse. For me, as I evolved into leadership, it's all about if you put the patient at the center of everything you're doing, the rest of it is easy. And so this roadmap, first of all, thank you to all the people who worked on it during the pandemic. It's exactly what we need to move forward. And the pandemic has created the perfect setting to take the next step. Because during the pandemic, what did we do? We huddled. We communicated. We worked as a team. We faced uncertainty. And in order to be able to care for our patients and for each other, all the fundamental building blocks that you need to move to the next step were put in place. So we will all in this room waste an opportunity if we don't take advantage of coming off of the pandemic and really using that foundation to build. And we can do that. I've been in the state many, many years, and we've had many great attempts and great tries at doing this, but now is the time. We don't have to go back and start from square one. For all of us who have successfully gotten through the pandemic, we have the infrastructure to do this at the most basic level. But at the end of the day, it does start with your board. And so board education is really important. My experience, I've been at Emerson going on my 19th year, is you have to engage your board. Your board has to go through high reliability organizational training. So you have to get them as excited about quality, not just the finances, as you are about it, as your management team is about it, as the people who work there every day are. So how do you do that? First of all, every year when you look at your mission, vision, and values, quality and patient safety has to be a core value. You got to write it down. They have to vote on it. You have to include it in your mission statement. You have to include it in where you're aspirationally moving as an organization. And then you have to tie measurable things to it. Every year we have a strategic action plan with a whole section devoted on quality and patient safety. And when all else fails, tie everyone's compensation to it, right? So, that does really help with that. So, to move forward with that, then you actually make it real. Now that the pandemic's over, we have started to introduce this, but prior to the pandemic, we require all of our board members to go on quality and patient safety rounds. Now, some of my peers say, oh my God, that's horrible. What do you think they're going to say? Well, if you put a good system and structure in place, you have open communication, first of all, nothing will surprise you. But second of all, you'll have a good idea what people will say and how you're going to address it. And you can't have that fear, right? So we take our board members, my Chief Medical Officer, Barry Kitch, leads them around the organization. Barry, raise your hand. Leads them around the organization, and we ask questions. But more important, when the questions are asked, it's how you follow up with your staff. And so when you get the board really engaged and excited through the education, and you start to take them to talk to real people in the organization, the people who do the work every day, and then even with permission to talk to patients, that's a force multiplier. That enthusiasm takes off. In fact, if anything, I sort of created a monster. We have a board quality committee that wants to meet all the time. They want to hear the good, the bad, and the ugly, and we do share that with them. I think it keeps us accountable for what we're doing, but having an engaged board is really, really, really important. And then you can cascade the training throughout the organization. And the high reliability training has really, really made a difference. Why? Because we're asking staff, how can we help you to do your job better? I always call them bad hair days, because I hate bad hair days, but how do I make sure you don't have a bad hair day when you come to work? What are the barriers? We put in a tool, RL Solutions, to help us to capture in writing. Now, we've gotten to the point where everyone's writing every little thing down, but I'd rather have that than them not reporting near misses and things of that nature. And again, the key is following up. So, to sum up, you really have to get the board to be engaged. Once you get the board and your management team, and you only pick people to be on your team that really believe in this and really want to advance it. And I do think having a clinical background helps, right? To be able to balance the clinical with the financial realities, because if it's unbalanced, you're never going to get to where you need to be. So start with the board, work down, and having tools that will help people, because from a hospital perspective, hospitals are all in various states of financial flux, so they can't all afford to have people come in and facilitate and train. But if there's how you can get educated and train your own, that will really help so that we can include everyone in this.
Actually, everyone else is providing health care, but you're obviously sort of working with Blue Cross, one of the major insurers here. And I'm curious, what's the role that the healthcare payers can play in advancing notions of healthcare safety? And obviously, Blue Cross has had substantial experience with using incentive programs to try to bring about changes in behavior, and I'm wondering if those can be applied to safety improvement.
Yeah, I was chuckling. So I'm looking around this room, seeing so many faces who knew me as an emergency physician at Faulkner before I started on my roadmap and journey in quality and patient safety. I was lucky enough to have had the financial support to bring in Paul Lesage and SG Collaborative Solutions to actually do that board training at Beth Israel Deaconess Milton. But I think when you commented on tying incentive to performance, I guess in some ways AQC ties incentive to performance. And so I think there's a front and center forward role that the health plan plays, but I think there's also that sort of concept of safeties behind the scenes, recognizing that it's heavily reliant on high reliability structures and processes. In the incentive piece to this, we saw an opportunity and did rule out incentives within our AQC contracts for equity. And it's starting with the basics of first being able to see the problem and then start to advance that in the way we advance the other AQC quality measures to drive improvements in performance on unacceptable outcomes in chronic disease, in pain management, in maternal morbidity and mortality. In shaping policy, I remember in 2012 I went into work and I saw a patient in the emergency department who needed that sort of classic medical clearance before they could be referred on for mental health evaluation and ultimately placement in an inpatient setting. And I came back to work the following day on the 4 to midnight shift, and that patient was still there. And I came back in on Sunday on the 4 to midnight shift, and that patient was still there. I went into a 7-day stretch off at the time and came back in on a day shift. A week later, you can sort of guess where the story's going, right? And this patient boarded in the emergency department for 21 days. And what they had for insurance was, we thought, was Medicaid from Alabama. And through that process and working with the Health Policy Commission CHART grant program, was able to get some of the funding for high reliability, but also to really start to look and reimagine how we're managing mental health and the delivery of that mental health in the ED, which is a safety issue. It is an unsafe environment to board for long periods of time in the emergency department. What turned out to happen was 21 days later, it turned out the patient had more than Medicaid insurance. There was a secondary insurer that we were not aware of. And I remember the director of clinical integration saying at the time, insurance is access. And today, I think in that sort of forward role that Blue Cross has had, we have helped shape a policy that puts mental health clinicians in all of the EDs in the state through the ABC Act, have helped incent safety around collaborative care models. And this morning, I've got a team of 6 psychiatrists at Blue Cross that are doing a huddle right now on the 10 patients that 10 members that Blue Cross has boarding around the Commonwealth. And that's a mix of general psychiatrists and child psychiatrists who are really sort of sitting there trying to understand the members' individual benefits and plan and come up with creative solutions to get them alternatives to inpatient care or residential care or outpatient care, as the case may be, but are doing that direct outreach to the ED to try and resolve that. We have a great relationship with the provider community. There was a tragedy on the South Shore several months ago, a woman who suffered from postpartum depression. What I was able to see in our claims is that there's a remarkable drug, Zulresso, that can be administered for postpartum depression. We know that it's challenging for OBGYNs to do the screening because they don't always have the destination to refer patients to when they screen positive. But what we were seeing was this drug is being administered at women and infants in Rhode Island, but there's nowhere in Massachusetts that's administering that drug. So reaching out to some of my colleagues in this room and the patient safety community, trying to understand and convene the OB chiefs and the psychiatry chiefs as to what it might take to create that sort of access in Massachusetts, so hopefully that incident doesn't happen again to another patient, another woman doesn't have to suffer. So just examples of our relationship with the provider community. I always taught, very small example, Blue Cross frees up my time to teach at the BU School of Medicine in Northeastern on the physician assistant program. I think one of the things that wasn't highlighted as heavily in the roadmap is that I really see the investment in the future clinicians. They're the ones that are going to look after me in about 20 years, hence my commitment to the PA programs. But Blue Cross frees up my time to teach at those institutions in the PA program, and I teach today on communication and quality and safety and so many of the things that I had direct exposure to during my time at Crico. So I think there's a lot there. And we have, to my surprise, things running behind the scenes that I didn't know health plans did. We have a team of pharmacists that every month takes a look at all of the members who are getting asthma inhalers that aren't on rescue inhalers that aren't on a maintenance inhaler, and we're outreaching to the provider offices, or in some cases where I had a pharmacist to one of the case management teams to outreach to patients, members, to give them education and find out why they're not on this maintenance inhaler. So some of the medication safety practices around medication reconciliation that you see in the hospital setting, we're also doing behind the scenes, that sort of less forward-facing role of Blue Cross, but I think there's things running in the background as safety often does.
So I want to ask a question about resources and also sort of look to the future. And it's always very difficult to predict the future, except if you sort of rely on demographics. And there you can really be pretty certain about what's going to happen. And MedPAC, which advises Congress about policy for Medicare, runs this graph that they've shown over the course of the last decade. And it basically sort of shows the number of workers who are available per retired individual in 2005 and runs it up through 2040. But the striking thing is that there were 5 people working in the United States for every retired person in 2005. We're now at about 3.8, and it goes down to about 2.5 by 2030. So that means that there's a tremendous kind of in the background ringing sensation in the healthcare system. We basically have a healthcare system, the way we run it today, that we can't afford in the future because there's just not enough workers to take care of all the people who will be getting sick and going into the hospital. So given that I think we can look forward to a future of fiscal constraint, probably some symptoms of which we're seeing today, especially with regard to the tremendous burnout effect you're seeing in critical areas of the healthcare system, like in primary care and in nursing. I'm just wondering sort of how you see in each of your areas sort of resources being available to address these patient safety problems. Ted, let's start with you.
Sure. So I think there's a couple of issues. You have the workforce issue, which has certainly been problematic, and workforce issue again through the entire vertical of healthcare. Looking at numbers of physicians, looking at number of people working, receptionists, looking at looking at the entire healthcare spectrum. I will say that where I practice on the Cape, we've done some innovative things, and I think that this is where at a very grassroots level, systems need to be innovative. We've partnered with 4Cs, which is a community college on the Cape. We've partnered with the vocational school. We have empowered our own workers to be able to get the tools that they need. We had environmental services workers when we realized that their impediment to moving forward was the fact that English was a second language to them. So we taught them English. We made them more facile in English and allowed them to do the most that they could do to rise to the level that they want to rise to by providing them the tools to do that. So I think a lot of that innovation will be there. We need to make the healthcare professions more attractive. They have to look attractive, again, across the whole vertical, from physicians, from everyone that's involved in healthcare. Why should you be involved in healthcare? How do we make it so that it's very attractive? There we could have a long discussion about at each level of how you could do that, but I think there are specific things that we need to look at. I will speak real quickly to some of the financial concerns that you have, because I was down in Washington a couple of months ago. The AMA has a national advocacy conference, and we sat with our congressional delegation, which is all Democratic, and they said to me, Ted, we go to our Republican counterparts, and they keep saying we can't spend any more money, and I said to them, guys, I said, you know what? We don't need to spend any more money. If you look at the OECD data, we spend almost twice per capita what other industrialized countries spend per capita for healthcare. Now, on average, we spend about 10 to 11,000. Other countries spend around 6 to 7,000 per capita. And I understand there are many drivers of healthcare costs, that there are questions around homogeneous populations and healthcare results. But the reality is, when you look at some of the seminal measures that we have for healthcare in this country, we fail. And we fail miserably. We also have had the first time that healthcare life expectancy here has decreased for the first time. And I think we really, as organizations, need to take a real look. And I think the work of what the Betsy Lehman Center is doing now is helping to drive that. Let's look at why we have a product that is not as good as it should be, given what we're paying for it. So I think a lot of those things need to be looked at as well, because we probably have plenty of money in the system, but we may not be using it as efficiently or as the best way possible.
Thank you. Michael?
Yeah, I spent probably from November to January trying to think about some of these critical issues that we're talking about today, in large part because of the role of co-chairing Governor Healey's healthcare transition team, and really smart people meeting to try to figure out and chart a course for the Commonwealth. And one of the things that, of course, kept coming up is the workforce crisis and the challenge we face. And I think connecting that to safety issues, that no matter what healthcare setting you're in, if you don't have the workforce you need to meet the demands of the patient population, there is a crisis. And that crisis, quite frankly, is going to be worse. So one of the things I try to lift up is the deferred care crisis. The fact that many people, particularly in communities where I come from, didn't get their teeth taken care of, their eyes, their mental health, their substance use disorder, or that pain in their side, which may have been a stage 1, maybe a stage 4, by the time that they actually come back into our system. And then, whether it was the pandemic and them not having an opportunity to engage in care, but now if they want to come back, now the delays are longer because we don't have the workforce to meet that demand. That keeps me and many other people, particularly in the health center space, up at night. I think we have to think very innovatively around this issue of workforce. I think, we've, in the Mass League that I represent, have really been central to this loan repayment program, the $130 million Program Plus program that we're running with the state to provide loan repayment is a piece of the puzzle to keep people in place, to give them some incentive to stay in the workforce, to continue to provide care. But that's only a shorter-term solution. It's a retention strategy, not a recruitment strategy. To the point that was made, I think we need to build a broader pipeline of that workforce of tomorrow. And I say this because it's so critical, because we should have known. It should have been a diverse pipeline. How dare we think that there are not brilliant black and brown folks who also could be physicians and nurses and serve in our healthcare system. And I would argue our crisis is in part because we ignored that diversity and we ignored that talent. So I think there's a lot of challenges that we need to face in the workforce space. It is something that I think I meet on regularly with policymakers, with legislators, some of whom are in this room, that say, Michael, what is the next train leaving the station around health reform and health policy in Massachusetts? Always comes up as workforce and health equity. And I think we have that challenge as a Commonwealth. And I think, again, as we always do, we can lead the nation in how we do it.
Very good. Christine?
So one of the things that we're working on at MHA is on creating a safe environment for people to work. So there's a lot of work going on with workplace violence. And we don't really talk about it, but it happens a lot. And I think people have lost their patience during the pandemic. Why? Because they may have to wait. I can't tell you the number of calls I get. I've been waiting in your emergency room for 30 minutes. What's wrong? Johnny clipped his fingernail the wrong way. And think to myself, oh boy. So, we really have a lot of education to do, but our staff sometimes feel threatened by that. There are actual assaults. So a lot of work has to be done on making sure the places we want to have people work are safe so that they feel like we are supporting them and creating safe environments. And that doesn't mean necessarily putting a security guard at every entrance. It means teaching de-escalation strategies and ways to be able to support our staff, and also having enough staff so that they feel safe in the work that they do. The other thing is understanding the generations. Why is it that a work week is 7 to 3, 3 to 11, 11 to 7, and 40 hours? And if you don't do that, then you can't work. We have to understand that different generations are looking for different things. And if we can be flexible with that, if we can try to meld the generational needs, wants, concerns, then we'll be able to fill more of our shifts with that. And so that's something that I think we're resistant to. Why? Because it actually takes time to be innovative and to be creative and to pilot programs that are going to help to address some of these strategies. But if you do, then that's going to go a long way towards helping people stay in the workforce longer. And that goes to helping people with their mental health, with their physical health, and who knows, with the way Medicare is going, no one's going to be able to retire anyway, so why not make a great work environment for people that they can, give back? And finally, the programs and the partnerships. So we often just think about the RN programs, but what about the LPN programs and the technical programs, and really cutting across the entire workforce of the organization? And we've engaged with many of the technical schools, because we need phlebotomists. We need people to register patients. I'm hopeful with Bed Bath & Beyond, which I love, laying off 14,000 workers. I'm putting a sign out in front of all the Bed Bath & Beyonds. Come and work with me. We need you. But as many of, on May 11th, when many of the things start to go away from a federal funding perspective and a state funding perspective, I think there'll be more people available to work that will have to work, and we need to be as warm, welcoming, flexible as we can to get people back into the healthcare workforce, right? So,
I'm watching the nurses in the room laugh at the Bed Bath & Beyond comment because there's a pun in there with Bed Bath, and it's a great Bed Bath. It's a great marketing.
And honestly, what about those coupons?
Actually, can you?
I'll pick up there. I mean, these are the musings of somebody who's been in this field for 30 years now, and it's overwhelming, right? I sort of think back to some of my training at Intermountain, that quality controls cost by 3 causal mechanisms: the inefficiency waste of building the right thing the wrong way, the quality waste of building the wrong thing and having to rebuild it or build something else, and then there's this technology advancement. I just approved a $3.1 million treatment for somebody with beta thalassemia last week, and I scratch my head and wonder how, as society, are we going to be able to manage this going forward? So I choose not to look at that piece and really look at the innovation piece. My mom's in hospital right now. She fell down the stairs and broke both legs in Quebec, but she's got a pharmacist that's coming in her room managing her antihypertensives. Right, there are workforces that we don't leverage in addition to the ones you referenced, Christine. 5 years ago at Milton, I approached the CNO and said, if we eliminated 2 nursing positions, which were empty positions anyway, we could put 4 pharmacy techs down in the ED and upstairs on the floor for the same salary. And my hospitalists and the nurses on the floor were doing dances around the nursing station because they didn't have to do medrec anymore. So there are things that we can do that are innovative, but also address that. There's 2-fers and 3-fers out there. They also address burnout. So I think there's lots of opportunity. Troy introduced me, and one of my sort of key areas is clinical innovative partnerships. There's a lot going on in the telehealth space where teams are reorganizing themselves, and again, it's not rocket science, right? It's teams of physician, nurse practitioner, dietitian, LICSW, practicing collaborative care models and addressing chronic diseases in ways via telehealth, and they believe that they can drive great outcomes. Some of the initial results are promising, and at a lower cost, and they're willing to take a substantial TME reduction when they contract with us, which we're able to pass on to our members as $0 copays. I think we have to spur innovation where it's occurring and fail fast. Right, it's not all going to work, but we can't stick with the status quo. And everybody in this room has their passion and their own area where they've got an idea that they can exercise. And I would just urge you to not give up the fight because of the $3.1 million drug for beta thalassemia. There are other ways to. It feels nickel and diming it at times, but there are other ways to get there.
Thank you. Well, we're ready for questions from the audience, but I think I would like to first just thank the panel for their prepared remarks.